Hey everybody, it's Karen Anderson with Aortic Hope. We are here a little bit later than planned because these things happen when you're dealing with surgeons. We we are here for our live Q&A tonight with Dr. Kyle Eudailey from University of Alabama in Birmingham. Welcome, Dr. Eudailey from Saving the World.
Karen, thank you for having me. Always a
You're very
pleasure.
welcome.
It's
You're
truly,
very welcome.
truly, you do great things. So I'm always happy to be here and help out
Thanks.
and do what I can with you.
Thank you. So you know what? Before we even get started, even though I told everybody tonight we were just going to talk about everything aorta. So you just had a situation where you had to go check in on a patient. And I'm just curious because every doctor does things differently. What what does it look like when somebody comes to you with a type B dissection, let's say?
Mhm.
What are these types of conversations look like? Like you had said to me, I need to just go put hands on a patient, which I
Mhm.
repeated that after we hung up because
Mhm.
I think that that's very interesting. And I hope that's being practiced everywhere and physicians aren't just going with what a scan says. I think it's important for that visual and the hands
Mhm.
on. I think it helps the patient. It gives you a little bit better perspective. So before we even talk about that, because I jumped the gun, tell everybody a little bit about yourself and your practice, and then let's talk about that a little bit.
Sure. So, Kyle Eudailey. So I'm a cardiothoracic surgeon. I practice here at University of Alabama, Birmingham. We are sort of a large, for people who are not in the South, and I'm not originally from the South, but we're a large tertiary care center in the Southeast. Um, I sort of run our aortic. We have an aortic specific fellowship, and then also sort of an aortic surgery program, which we are sort of more carefully formalizing, but we'll be the director of that. And we see a lot of aortic pathology in the Southeast. Part of that is because there's a fair amount of um, aneurysm pathology, and there's also a fair amount of uncontrolled hypertension, but it's also our catchment area. And so we end up being a tertiary referral center for the all of Alabama, lots of
Mhm.
parts of Mississippi, parts of the Panhandle, and even parts of Tennessee and Georgia. And so because of that, as an institution, UAB does about 2,200 open hearts a year, and multiple hundreds of aortic cases a year. And so we see a lot.
Mm.
Um, and I've been here. I'm originally from Massachusetts, did all my training in New York at Columbia, and have been down here for, let's see, since 2017. And it's
Yeah.
great. It's a great place, and I'm really sort of blessed to have good partners and great staff and a great institution, and we're kind of very proud of what we've been able to do here at UAB. So
Very good.
that's a little bit of the background of us and UAB and sort of the team. Um, the second part of your question. So I love that question on so many levels. Partly because I say a lot of the same things to my fellows and trainees. Um, Dissections in particular are kind of funny animals, right? Type B and type A. Type B is obviously the dissection that exists past the left subclavian. The type A's are the more malignant, kind of nastier pathology. Those are when you have a tear that's proximal or closer to the heart. Type A's are usually a surgical emergency. Type B's, though, can be managed medically, depending on how the person looks. But in any scenario, type A or type B, it is something that is primarily diagnosed usually by a scan, right? A CT scan is the ultimate diagnostic tool because that tells you where the tear is, where it's located, where the proximal extent is, where the distal extent is. But a CT scan only gives you a brief snapshot of what's going on, meaning that
Mhm.
dissections are dynamic, um, you know, dynamic entities, and it's a dynamic pathology. And the reason dissections can be such a nasty pathology is that it can change, and a patient can get really sick really quick. And so often we are, as surgeons, sort of given scans and told, well, this is such and such, and this is their history, and this is what the scan is. But I always tell my residents, and personally, I always try to visually go and examine a patient. And part of it is because there's there's a clinical gestalt that you get when you see somebody and you kind of understand, oh, this person's a lot sicker than you thought, or this person's not quite as sick as you thought. And there's just so much in terms of how to unpack that, and it has to do with, is the dissection itself quasi-stable? Does somebody have evidence of malperfusion, meaning, are they not getting blood flow to a certain area of the body? And a lot of those things can be evaluated on a clinical exam. And sort of the simplest aspect of how a patient feels, particularly when they have a dissection, can tell you a lot, right? I mean,
Right.
sometimes you see scans and you say, oh, that doesn't look that bad. And you go talk to the patient and they have this, they feel terrible. They're having belly pain. They're having this crushing sense of doom. Those are people you got to get to the operating room, because it's something bad is happening that hasn't even shown up on the scan quite yet. And the patient will show you. And so it's part of the reason why dissections are so fascinating. They were type A dissections or even all dissections fell under this, classically were called the great masquerader, because they could be they could present in so many different fashions. And so, I think that's why it's kind of an interesting disease process, because we still don't fully understand it in its entirety. And so there's always something to be learned when you take a scan, you take a history, and then you pair it with sort of how somebody presents, because it gives you, some additional information, and also guides your clinical judgment as to, in a scenario of a type B, can we manage this medically, or is this somebody we have to take the operating room and stent emergently, right?
Yeah.
And so, it's I was walking out of the hospital. I was coming to sit down to try to talk to you, and sure enough, I'm on call for dissections tonight, and I kind of turned right back around and walked back to the ICU because I had to go see this lady who just gotten a scan. So there's a lot to be learned from that, and unfortunately, I think people are moving away from that, because in this day and age, so much of our training, we rely on computers and EMR for information and scans and labs and all that. But there is a wealth of sort of clinical information that exists at the bedside.
Yeah, I'm glad that you
hard.
said that, because I just had a meeting with some people from the American College of Emergency Physicians. And, it's so interesting because they're getting him right in the ED, and they are talking about how challenging, just how incredibly difficult it is, because they don't see dissection patients that often, depending on the hospital system, but how hard it really is to get to that point where they decide a CT is necessary. And I know that some hospitals are signed on to, how do I say it? A scoring. I'm trying to be very politically correct. A score or an algorithm using AI to determine how do we proceed. And I think back to my own case, and I think with the hospital I was at, knowing that I had Crohn's disease and me coming in not really horribly uncomfortable, some reflux pain, a little pain in my neck. How did I get so lucky that something they heard, something they felt, something led them to say, let's do a CT, just even though I'm very allergic, they somehow got that pre-medication in me very quickly and had me scanned. But if I had been thrown to this algorithm, this AI predictor, which I didn't even know about my father's medical history or even sharing half the stuff that I did, as I do now, would I have gotten that CT if it was based solely on a computer? So that's why I think those computer modeling systems, and I don't think it's because I'm older now and I'm, going against the grain of this new technology, but it does scare me to not have a physician that wants to listen to this flutter I'm feeling or check the pulse in both sides to see they're 20 plus off, So I'm just wondering, what are your thoughts about if these things might change for the better or stay the same or get worse in the ED? Because that's before it even gets to you.
Yeah.
So how do we get people to think about the aorta, which is always something I'm trying to do?
I know. I tend to be an optimist, and I generally think that it's going to be for the better, right? I mean, a lot of these algorithms and things that we're only starting to just barely scratch the surface of. A lot of them will probably aid in detection, right? I mean, part of it is, when you're in the emergency room, and you're an emergency room physician and you only see one dissection a year, right? Or at best 4 or 5 a year. It's hard for somebody to that be on their differential or top of their list differential, because they have another 1,000 to 2,000 encounters over the course of the year where that's not even close to the case. So it's really a rare event, right? There are some scoring systems that the emergency people use, right? There's the aortic dissection risk score, which is actually pretty interesting and has been validated in terms of whether or not to screen, whether or not to get a CT, and it has to do with just history, basic history, meaning that often the funniest thing about a dissection is this sort of sudden onset of something, right? And now I don't know anything about your own presentation, but even with Crohn's disease, or even with some other abdominal history, often people sort of describe this sort of sudden onset pain or something very different, and people can't put words to it, but often it is, hey, this is different than something I had before.
Yeah,
right.
That's true.
And again, it's not like you've ever told me exactly how you presented, but a combination of sort of the sudden onset, any family history, and then any high risk exam feature, which is really simple, meaning pulse deficit, blood pressure deficit, which you mentioned, focal neural deficit, new murmur. You combine that with a D-dimer in the emergency room, and actually you have pretty impressive sensitivity and specificity in terms of testing for a CT scan. And then obviously a CT scan is the ultimate answer. But it's hard because you don't want to also say every person gets a CT scan no matter what, so that nobody has to think. And so, my hope is that a lot of these uses of AI are going to drastically improve the ability of people to screen for these sort of lower or low incidence events like dissection. And then the other aspect is that you have to keep in mind that a lot of times CT scans are done and the contrast is not appropriately timed. It's a PE protocol. There's a whiff of it. They call it a dissection, and the reality is it's just an artifact from the scan not being appropriately timed. There's a lot of AI that will be able to better use the CT imaging to pull out true dissections, meaning that patients will be evaluated quicker. It'll be more readily identified. You're not relying on a tired radiologist to review it in the middle of the night. Not to disparage radiologists by any means, but there's probably a benefit that we don't know about too. And so again, from like I said, I tend to be a glass half full type of person in general. And so I think that there's going to be a net positive based on a lot of this, but how it gets used, man, that's going to be the $1 million question, because it's going to change a lot of different stuff.
Exactly. One of the things we were talking about today, we were reviewing from last week's post, where the aorta, the organ, right? Because we were reviewing that has been about a year, right? Since it is now an organ. And what does that mean? And we talked about the zones 0 through 11. And we were kind of talking about how these zones really make a difference in the way that you would diagnose or monitor or treat, et cetera. And so I want to talk a little bit about these zones and why is this important now that the aorta is called an organ. I tried my best to explain it, but I tell people I'm not a physician. I just play one on TV. What this means, and how did people get to this conclusion that we're just going to bypass the importance of it being a vessel and we're going to actually deem it an organ?
I love it being called an organ. I love that delineation. I think that's a big win for all aortic surgeons and people who treat aortic pathology. The best way to think about it is that, nothing in the body is by chance, right? I mean, there is a grand design as to how things are made, and they are not made with the Luddite thinking of it just being a pipe, right? There's no way. And so the body is designed with so much more elegance and so much more nuance. And so the reality is, if you get down into the weeds as to how the aorta works, it's fascinating, right? It's fascinating
Mhm.
because it's not a pipe. It's actually this compliant sort of organ. And so the reality is if you think of the best way to think about it is, the heart is this just, beast of an engine, meaning that it is
Mhm.
a ball of muscle that can eject blood as hard as fast as you could ever imagine, and it does it 365 days a year, and it shoots blood out like a rocket ship out into the body, right?
Mhm.
The trouble though is that's a pretty crude way to perfuse the body, because you don't want somebody, basically shooting like a shotgun to get
Right.
blood to places. And so the way that the aorta works is actually there's this incredible compliance, meaning it takes this sort of violent event of blood ejecting from the heart, kind of catches it, and then allows that energy to slowly diffuse back to where the blood can then kind of come out in a more laminar fashion to the body. And so that's actually something called the Windkessel effect, which is
Okay.
a very fascinating physics term. Because the reason this is interesting is because when we replace aneurysms or replace aortas, whatever we're putting back in there, it's not as perfect. There's
Mhm.
these Dacron tubes, they're fine, they're great, they're durable, but there is an element of where it is less than of a native aorta, right?
Mhm.
And so there's probably some significant benefit to how that aorta works, right? But there's also there's a reason why type A dissections and type B dissections, why those tears happen in certain places, right? If you look at the aorta as it goes up in curves, the first curve is where type A dissections happen, right? The reason why they happen there is because that is the highest area of shear force in the body,
Mhm.
and that's where the aorta is trying to handle and absorb all of the energy from the blood coming out of the heart.
Yeah.
And so, eventually sometimes the heart wins in the setting of either there being an aneurysm or there being some sort of genetic aortopathy, or tissue being not quite as strong. And that's when the tear happens. But the aorta is an organ because it's trying to basically take this shotgun of blood and then allow it to be diffusely go out into the body in sort of a more smooth manner. And that's really the beauty of it. And that has big benefits to the heart as well, right? So
Mhm.
there's some element of when we replace aorta completely, or people have lots of stents or frozen alpha trunks or these things where you've removed all of this native aorta, there's actually an increase in afterload on the heart. And there's some people who actually end up in worsening heart failure when they have big
Wow.
aortic procedures, because their heart now all of a sudden does not have that kind of cushion or catcher that it's had
Mhm.
its whole life. So I think
Interesting.
that's interesting because there's just so much that we still don't fully know about it, right?
Mhm.
I mean, we have a decent understanding of where aneurysms come from, but we still don't fully understand where aneurysms happen or how they happen. I mean,
Mhm.
there's a mechanical aspect, but there's probably a lot of other aspects that we're just sort of starting to unpack and peel the layers off of. And that gets to the fact that it's an organ, right? It's its own thing. It has its own,
Mhm.
it has its own system and its own, feedback loops and all sorts of fancy stuff in the
Yeah.
body that we see in every organ in the body, right? And that's the sort of elegance of it all. The
So would there be
zones,
I'm sorry, go ahead. Continue.
I was just going to say, the zones are really more just so everybody's on the same page and you're
Mhm.
speaking the same language, right? And
Right.
that's really important, just from a, you know, um, everybody's just discussing the same aspect of the
Yeah.
aorta.
Kind of
Everybody's
like
kind of speaking a common
Stanford,
language.
DeBakey, and now
Right.
we've gone beyond that, and now and those were different languages for the same thing anyway, a little nuanced. But
Right.
so before I get to my question, which I have to write down because pumphead, I'll forget. Okay. So getting back to the zones, we were talking today, and somebody online commented that her doctor said that her dissection in zone 2 was a type B dissection. I think I have that right. And I was like, well, I'm wondering if it's because it's closer to 2 becoming 3 versus closer to the number 1. I'm like, I don't know. That's a good question. And I
Yeah.
thought I'd throw it in tonight.
So there is it's a so all right. I guess what I would say is I consider anything proximal to less subclavian a type A. I do
Okay.
that because that is in terms of the malignancy of it, meaning an
Mm-hmm.
arch tear is relatively malignant because The easiest way to think about that is because when you have a tear past the left subclavian, the subclavian itself is almost a backstop to the tear, meaning that the subclavian is a fixed structure that the tear can't retrograde go back against.
Okay.
When you have a tear in the level of zone 2, your subclavian is no longer that kind of backstop, and those are high risk tears. Okay. Now, there is debate about how to treat those. Whatever you want to name it is also, I guess it's not up for debate, but the STS came out with a nomenclature system that is designed for research purposes. And the nomenclature system delineates the location of the tear, the proximal extent, the distal extent, and then whether it's A or B. And so those type of zone 2 tears technically get labeled as a B, but then fall under the, basically with the retrograde aspect of it. You know, the long story short is the treatment is still leans a little bit more towards an A treatment, meaning they tend to be more aggressive in terms of the treatment. But that is a that's not a wrong statement.
It seems like it feels like it's the gray area, like it's the, all right, so it technically could be B, but we should probably treat it a little bit more aggressively, watch it a little bit more closely, because you're in that warning track. You're really in the you are in the track. So it sounds like, because
so it has to, it just has to do, and it just has to do with the exact location of, like I said, the location, how they get identified, and then how it is coded within from a research perspective. And that has to do with both the STS and the SVS agreeing on the nomenclature, both for the registries.
Gotcha. Okay. It's a lot of words there, Dr. Eudailey. Lots of big words.
I guess the point is that
no, it makes sense. No, you do. You make sense.
But it is technically a B based on the STS reporting standards.
Okay.
Now I would still consider it a type A, but again, there's people who disagree with that. But that's again from a reporting standpoint into the registries. It's based on this. There's a paper that from 2020 that was STS and SVS that talked about that.
Okay. So then the question that I was going to ask is, I think we're the only organization that just offers education, information, and support for the entire aorta. I think we took that on. It's a lot, I know, but we really begin at the valve with any type of aortic valve disease or congenital, and we go through aneurysms, non-aneurysms, all the way down. And then there are some people out there that feel that it's more important just to focus on thoracic aortic disease. And I'm wondering what your thought is on that, because I think by doing that, you might give the perspective to people that if it happens in the thoracic area, it's not going to happen in the descending. But if it happens in the descending, you don't need to worry about it. And it just kind of how it makes the public feel, I think, that one is much more important than another. And I know what we have seen is that is absolutely not the case. I have quite a few people who had a type B, or they had something in their abdominal area, and then 10 years later, ascending. My father had an abdominal aneurysm, and I ended up having thoracic, so ascending. So I just want to know your thoughts about that. Is there this delineation between areas?
So I think the trouble is that you end up having a split of providers who treat the aorta, right? And that I would agree with you. I think that you should treat from the heart all the way down to the legs, basically. And the reason being is what we mentioned earlier, meaning the aorta is an organ, meaning it's all the same tissue. And so it's important to understand that you can be higher risk if you have aneurysms in one spot, and it's just, you're at higher risk for them coming up in other areas. Now I'm a cardiac surgeon, and so I have a strong preference to deal with the any and all thoracic aneurysms, right? And a thoracic
Mm-hmm.
aneurysm is anything that's in the thoracic cavity. So that's
Mm-hmm.
the other important distinction there is thoracic aneurysms are ascending aneurysms, arch aneurysms, descending aneurysms. They're all thoracic aneurysms.
Mm-hmm.
And so it's important that everybody understands that when they're talking about a thoracic aneurysm, it still could be any number of, any area. It could be multiple different areas, and this gets back to also the zone issue, meaning that
Mm-hmm.
if you refer to an aneurysm as to its specific zone, then everybody's on the same page in terms of they're speaking the same language.
You're pretty
Now,
much talking about up to the diaphragm or just a little bit
above the
beneath.
diaphragm, anything above the diaphragm,
Everything, right? Okay.
right? And that's zone 0 to zone 5, right?
Mm-hmm.
And so zone 6 through zone 10 are really below the diaphragm and down
Mm-hmm.
to the groins. But that is often dealt with by vascular surgeons, meaning most cardiac surgeons are not dealing with aneurysms below the diaphragm, and partly because there's a lot of nuance between those areas.
Yeah.
I would tell you that probably the most important thing to understand from a patient perspective is that you want to go somewhere where there's a good multidisciplinary aortic team.
Yeah.
When I have my clinic, I have clinic on the same day as one of my vascular surgeons. Just today, I mean, there were 2 patients where they were seeing me, and I told the patients, I said, listen, I know you're here to see me, but you really need to go see Dr. Beck. His name's Adam Beck.
Mm-hmm.
He's a wonderful vascular surgeon, and we do a lot of stuff together. I said, really need to go see Dr. Beck because it's kind of, this is a little bit more down into his wheelhouse versus my wheelhouse. And so, but it's very fluid, the transition, meaning that it's all the time where he's sending patients up to me, I'm sending patients down to him. And at the same time, we meet once a week to go over shared patients to kind of discuss plans, because a lot of times we have aneurysms that are extending from the arch all the way down to the groins. And so we need to have a kind of a shared plan as to how we're going to approach it in a staged manner all at once. Endovascular versus open. And so what you want is a team mentality where you have people who can kind of do a lot of different things. The biggest issue is if you go somewhere and you're dealing with just one person who is not going to be able to offer you the kind of full complement of treatment options, then that's where you're limited as to how you can get treated.
Right. I want to ask Joshua if there's anybody online we need to say hi to or chat with.
Oh, we have quite the group with us today. We're going to start by saying hi to Rob and Belda and Tom and Christina and Brenny. Rob asks, can you quickly identify the different zones?
Yes. So the zones they have to do with sort of anatomical landmarks. And so the first zone is zone 0. So zone 0 is anything from the aortic root all the way to the innominate artery. Then there's zone 1. Zone 1 is from the innominate artery to the left common carotid. Zone 2, which is from the left common carotid to the left subclavian. Zone 3, which is just past the left subclavian. Zone 4, which is kind of the midsection of the descending thoracic aorta. Zone 5, which is just above the celiac artery. And then you have zones 6, 7, and 8, which are at the celiac, SMA, and then the renals. Zone 9 is the infrarenal aorta. Zone 10 is the iliacs. And then zone 11 is when it splits into the internal and externals. And then zone 12 is femorals, I guess.
I will share my screen real quick because this is what we were talking about. Did that work? Maybe it did. Am I up yet? Do you see my screen?
Mm-hmm.
Okay. So this is what we were talking about from last week. So this is everything that you just rattled off, which I'm sure was 100% from memory. So this is a good way to answer your question, Rob. And you can see all of that all the way down. So if you check out last week's, what was this? Topic Tuesday, you'll see this graphic right there. A good question. Anything else, Josh?
We do have one that dropped into the anonymous.
Okay.
A question about medication during the watch and wait period. Are calcium channel blockers like amlodipine safe to take for blood pressure control? I saw some reference to CCBs perhaps causing aortic tissue damage. I take metoprolol, 150 milligrams, losartan, 100 milligrams, and recently added amlodipine, 10 milligrams. My BP now averages 110/70. I have a 4.2 ascending aortic aneurysm and have been monitored for 6 years. I have no genetic issues and a trileaflet aortic valve. Thank you.
So so what I would say is that amlodipine is a good blood pressure medication, right? The reason it's good is it's once a day. It's relatively well tolerated. Sometimes you can have lower extremity swelling, but other than that, it's usually has minimal side effects. And for that reason, it serves its purpose. All right. If you are now, preferentially, we tend to start people on beta blockers because they do have an anti-impulse element to them, and they're very good from a cardiac standpoint if you have any associated cardiac disease. And then there's a sort of next step is either ACEs or ARBs, which is either lisinopril, valsartan, losartan, that type of thing. Reason for that is because they also have some evidence of reducing aneurysm progression, but that's mostly in the Marfan population, not necessarily in the general population. And then if you have any chronic dissection pathology, ACEs or ARBs can be good as long as you don't have any associated kidney disease. Those are also once a day and usually well tolerated. So, I would say that typically we lean a little bit more towards beta blockers and ACEs and ARBs. I also preferentially, I like hydrochlorothiazide. It's a very easy blood pressure medication. It's been around forever. Again, also well tolerated. But those are kind of the first line medications. There's nothing that I know of concrete that would suggest that calcium channel blockers are that increase any risk of sort of aneurysmal degeneration. And so from my standpoint, we use them all the time. The other thing I would note is just from a personal standpoint, if you have a 4.2 centimeter ascending aorta, in my opinion, that's just dilation. You're not even you don't even have an aneurysm. So I would say, you shouldn't even be worried about anything. Live your life, no restrictions, right? Because from anything between 4 and 4.5 is dilation, but not aneurysmal. Typically anything above 4.5 is more in that quote unquote aneurysm range, but again, not anything you have to do anything about. But at 4.2, depending on how tall you are, but that's kind of not even close. I would just say that's technically ascending aorta dilation. And the reason that's important is because sometimes you put aneurysm on your medical record and then people freak out and they don't want to touch you or do anything about it. But that's dilation in my opinion.
All right. I have a question. This is kind of in reference to that. So there was a person who was diagnosed with a 4.7 ascending aneurysm from an echo. 1 month later, they had a CT angiogram with contrast and showed a normal size aorta. The internal medicine had another radiologist look over the CT, got a second opinion, and they had the same conclusion, no abnormalities. So why such a big difference? I mean, I can understand a couple millimeter, but 4.7 centimeter.
Right.
How does
So
that happen?
this is, your an aneurysm is, really only diagnosed very well on a CT scan or CTA, right? CT with contrast.
Yeah.
Actually, I guess I should also say MRI can be pretty good at doing that as well, but MRI is a lot, MRI or MRA is a lot more underutilized, mostly from a cost and convenience perspective. But an echo is okay at evaluating aortic root size, but very rarely is it good at evaluating ascending aortic size. And the reason for that is an echo is really, echoes are only as good as the sonographer, meaning the person doing the echo, or the person's windows, meaning that when we call somebody, their sonographic windows are how easily you can see their heart. Some people, for whatever reason, their rib sits in a certain place. They're either barrel chested or kind of big. They have hyperinflated lungs. All these things can make it to where the echo is really, the imaging is just not very good. And the other aspect is often when you're using an echo probe, you're limited by the way in which the ultrasound waves can hit the heart. And so if you take an oblique measurement of the aorta, it can be much, much larger than it actually is, because what happens is if you have an aorta and it's kind of making a big turn here like this, and you cut it as it's making its turn, it'll look as if it's much bigger. Or if you cut it to where you're not measuring the aorta in a perpendicular fashion, meaning perpendicular blood flow, then that's not the size that we care about. So the only way to truly measure an aorta size is if you measure the aorta's size perpendicular to blood flow. And so that means that even all CT scans are not created equal, because some CT scans are really poor. They have poor image quality. They're not timed right, or the radiologist is just being a little lazy and doesn't want to read it in terms of actually doing what we call a centerline measurement, meaning measuring the blood flow and then doing a measurement perpendicular to the blood flow. And so, all aortic scans need to be measured from perpendicularity to the blood flow, and that's the diameter that you need to be most concerned about. And this is probably the most common issue I deal with when I see people who refer to me for aneurysms, meaning poor image quality, or their scans were just misread. And so more often than not, I tell people, I said, listen, until I tell you the size that it is on the reading, everything else, just consider it wrong, right? And not to say it is wrong, but the trouble is, and that's what people worry about. They say, oh, it went from 4.7 to 4, right? I mean, how did that happen? It was never 4.7. It was always 4, right? Or the other thing is, people come in and they tell me that it was 4 and then it's now 4.7. And I tell them that, again, it was never 4, it was just misread, and it probably was 4.7 the whole time.
Right. And let me tell you something that happened to me. And I say the same thing you say all the time. I say, just wait until your doctor actually puts their eyes on it and measures it themselves. And that's when you'll know if there's something you need to worry about or no. Because for years I was told I grew to 4.7 in my root and another area in the descending. And so, look, the mind can play a lot of tricks on you. And it's not that I fabricated shortness of breath, because it can be proven on a test. And it's not that I fabricated swelling, because can be proven. And I do have an issue with my valve. But then all of a sudden I had my first CT in a very long time, because I'm highly allergic. So they use that very sparingly. And all the other tests were MRAs. And the CT says 4.3. And I said, well, that's an impossibility, because these things don't shrink. And the doctor's like, but it's just because it was not measured necessarily correctly. Not that an MRI is wrong, but between that and the echo, he's like, no, I looked at it. It's actually 4.3. And I was so frustrated, because then you have to wonder, did I maybe make myself more anxious, because I'm thinking I'm creeping closer and closer towards needing something to be done? And I can honestly say the answer is probably partly yes. And I know I'm not the only one out there. And so I think it is really important to, if you can have a CT, even though I'm so allergic, I had to pre-medicate for an hour. I think I probably took the world's consumption of prednisone in that one day. And enough Benadryl to knock a horse out. It was terrible. But at least I got the right measurement, that I needed. And I think that having that conversation with your physician directly makes all the difference in the world than reading it on the paper. It's just scary.
I think we've talked about this before, but particularly with root aneurysms, we've gotten, I think we discussed this even before, but again, this idea that the aorta is its own organism, meaning it's its own organ, and aorta is a dynamic aspect of the heart. And so, especially the aortic root, there can actually be upwards of 10% or 20% size difference throughout the cardiac cycle. And so when you get into root pathology, or people with root aneurysms, the best test is a cardiac gated CT, right? And a cardiac gated CT is when you do a CT scan that measures the aorta at the same point of the heartbeat every time. And so, for root pathology, usually you want to be getting the root at some point during diastole, because that's when it's biggest. And what you do is, when you do a cardiac gated CT, you limit the motion artifact from the aorta, and by limiting the motion artifact, you get a really precise measurement. And so, sometimes the more precise measurement's smaller, because there's less motion artifact and less, blurriness, right? I tell people it's like imagine trying to, it's like using an old style camera where the shutter speed's not good enough. You're going to get some sort of blurriness if you take a picture of somebody running by really fast.
Yeah.
But at the same time, sometimes when you do it and you get the proper phase of the CT scan and diastole, it's bigger, and it's bigger than it was before, because that's when it's going to be at its biggest, and that's when you need to measure how big the root is, right? And
There's so many factors that go into it that as patients we probably should just let all that go. Like, that's the last thing you can't control. Let it go and let it be somebody else's problem. Make our lives a lot easier. I do have a personal question, and I'm getting ready to have, and I haven't asked anybody about this yet, not even my doctor, my first congenital MRI. What in the heck is that, and why do people have that done?
Well,
I will tell you
MRI.
back history. My dad, I believe, because my mom's been tested and came back negative. I have FLNC, so we both have, I'm assuming he had the same cardiomyopathy gene. So I don't know if that plays anything into it, and that's why she's deciding to do this time around, but I never knew what it was, and I thought better for me not to look it up. Better for me just to find out.
But sorry, it's not a cardiac MRI.
It says congenital. It could say congenital cardiac, but I just remember the word congenital for sure, and I thought I'd never heard of that before.
Yeah, I'm not exactly sure what that would entail, to tell you the truth. That may be, usually when they do a congenital MRI, they're looking for just abnormal structures, right? Which are classically associated with congenital abnormalities, but from an adult standpoint, I'm not sure.
Okay, well, I say yes.
It may
thank you.
It may just mean that the way it's set up, that the protocol is done in a manner so that they're better identifying the structural aspects of the heart.
Sure, I'll take that.
But I can't speak to that.
Okay, I stumped you.
I certainly don't order a congenital MRI every day. If somebody's ordering it, it's a congenital, an adult congenital cardiologist.
Josh, is there any other questions?
Let's take a quick look, shall we?
Okay.
Rob says thank you, and nothing new in the anonymous list.
Okay. I have two more that I can ask here, and then I'm going to let you go because you're probably getting hungry, because it's been a long day for you. So, person has a history of high blood pressure only, 55-year-old female, has had 2 ultrasounds pre and post dissection, ultrasounds done on their kidney. A cyst is present on the kidney, and the scans are gauging if there's any growth. The next one's in 6 months. Is there any connection between type A and kidney issues?
Type A and kidney issues, no. Now, there is a connection between polycystic kidney disease and hypertension, but no specific one that's regarding type A dissection and kidney disease.
Okay.
And that does not sound like polycystic kidney disease.
Sounded like a cyst.
It sounds like a cyst, and a lot of people have cysts, so it's not. That's not kind of the.
And of course, they don't call them cysts; they call them hemangioma. Got to have a big fancy word, makes people scared.
Well,
or is that different?
That's different.
Oh, okay. Is hemangioma more like a birthmark?
Hemangioma is more like a birthmark. Hemangioma has vascular aspect to it, whereas a cyst usually does not have a vascular aspect to it.
Okay, so you learned.
But that's kidneys are, again, you're pushing the limits of my knowledge with kidney cyst questions.
Okay. All right, this person's 4 months past the unexpected AD surgery, was tested last night for sleep apnea, snoring 2 to 4 wake-ups a night. If that is positive and this person does have apnea, how important is it to get a mask for nightly sleeps?
Sleep apnea it's important to address sleep apnea from a hypertension perspective. So sleep apnea can be a driver of hypertension. And so sometimes there's actually a benefit from a blood pressure control standpoint with CPAP or, use of CPAP. The flip side of that is usually, not always, and I'm not presuming in this case, but usually, especially with adults with CPAP, sometimes there's some central obesity that's driving some of that problem, meaning that weight loss also can be an equally effective tool against it, meaning if you really absolutely don't want to get the CPAP mask because it's annoying or frustrating, if they believe that it might be due to that, just some a little bit of a belly, weight loss is probably the best thing, and there's big benefits from a blood pressure standpoint from a weight loss, and then also usually CPAP gets better.
But you know what the person actually said? The number one reason why whoever this person is doesn't want to wear it is because they don't think it's sexy. That's what they wrote. It's not very sexy. I'm just saying
Well,
what
me,
I
you
read.
know, if then
And
again,
try to
all the
lose
more
some weight.
reason why weight loss might be important.
Exactly. All right, I have actually the final question because this was
Okay.
a good one. What has your experience been, and how have you treated the effects of type A dissection and valve replacement and being put on bypass and its correlation to PTSD? What are your thoughts about that?
Yeah, PTSD is usually, at least in the setting of dissection, usually the PTSD is not from the, bypass and surgery. It's usually from the preamble leading up to surgery, right?
Yeah.
When you get diagnosed with an aortic dissection, if you have an excitable, ED doc, they tell you got a serious mortality problem and you're going to die if you don't get surgery immediately, right? And
That kind of does
there's
it.
probably a better way for us to deliver that news, right? From a medical profession standpoint. And then often people are rushed somewhere for surgery, right? And they're taken, if they're not in a dissection center where they can do surgery, they're either life flighted or flown or put in an ambulance and rushed there. And then a lot of times they get rushed once they get there, and sometimes they don't meet their surgeon ahead of time. They just kind of get rushed to the operating room. That is probably the most traumatic aspect to it, and it's not necessarily the surgery itself. It's probably all that beforehand. I don't have a magic answer as to how to fix that. What I tell people, because sometimes people after surgery really do, they have trouble, they have anxiety, they have PTSD, they have, I tell them, especially if they did well, right? I mean, there's a huge silver lining there. I mean, I know it was not an enjoyable experience, but it's okay to be thankful to be a survivor, right? It's okay to be thankful that you're not one of the statistics. I mean, I tell people, and I'm sure you know this, but right, no matter what, even if you make it to a hospital with great aortic surgery, the risk of death is probably still somewhere between 15%, 20%, right? And that's a crazy statistic. That's crazy. Most of the surgery that we do, the risk of death is somewhere between 2 to 3%, and that's our open heart surgery or elective open heart surgery, or probably even less than that. I'd say 1 to 3%. And so to say that you have a surgery that you're talking about the risk of death being, 15 to 20%, I mean, that's high.
It's very high.
And so if somebody survived, I think it's usually worth trying to focus on that, right? To say, you made it through. You didn't have a stroke. You didn't die. You're not on dialysis. I mean,
didn't lose any limbs.
Didn't lose any
all of
limbs,
that,
right?
yeah.
I mean, and even if you did have one of those complications, it's still, if you have a clinical malperfusion, meaning if you have a leg that's down or an arm's down, or you have a stroke, I mean, your risk of death with clinical malperfusion is probably close to 30 to 40%, right?
Yeah,
Depending on where it is. And so it's kind of I don't think there's any way to magically get rid of the trauma of the event of when it happens, but I think we can do a better job of maybe not panicking to people, meaning you just sort of say, listen, you had a dissection, we got to go to surgery.
It's amazing that you just said that. It's been 10 years and 4 months, not that I'm counting. And that's the first time I think I've ever heard somebody actually recognize that it can be handled better. And I'm sure for some of the local regional EDs, they look, because I've seen panic on their face, My doctor looked down when I said, "Are you telling me I'm going to die?" Because I had just seen it on a Dr. Oz episode. So I knew still in those moments what was happening. And then after that, once you get all fuzzy in your head or they give you some Versed, you don't remember much after that. But But yeah, when you're told in a panic state, you got about 2 minutes to decide where we're going to life flight you, it's not the most comforting thing that you hear, and you're grasping for anybody to tell you that you have a chance of living. And I think it's probably easier just to be told, well, there's been a serious incident, but we're going to take you someplace. It's going to take care of it. They're waiting for you. Make it at least sound like we've
Mhm.
got you,
Mhm.
instead of, we're holding our breath because if you sneeze, this could be the end of you. And that's kind of how I think a lot of places make you feel. And that really fuels this fire of what's
Mhm.
going on behind the scenes that you're not even
Yeah.
aware of when your brain puts it together.
Yeah. I mean, I genuinely try to tell people, listen, there's no decision you can really make at this point.
Right.
You just need to be, you're at a place, when they come to UAB, we say, listen, we do a lot of this.
Mm-hmm.
You're going to get the best care you can get.
Yeah.
I can't make any promises, but we got you, right? I mean, you're in the right spot now. But again, unfortunately, dissections don't happen at 8 a.m. every morning, right? They
11 p.m.
right.
Right.
And so, we get people life flighted from all over the state and 4 or 5 hours away. And, we try not to wait. And so, like I said, is we try to just get them in the OR. And so it's tough, right? Sometimes
Right.
people, they get life flighted somewhere, their family doesn't come with them. They don't get to see their
Yeah.
family before they go to the OR. I mean, there's all this stuff that we're not great at dealing with, but that's probably where a lot of that PTSD comes from. I don't think it comes, there's nothing from the surgery that
No.
would give you any reason for that, but it's
I
everything
think,
before.
and I think what happens after the surgery is more of that short-term memory pump head stuff.
Mhm.
And then when you couple that with all of the anxiety and stress and the possible PTSD from before, it just magnifies it. When you can't come up with a word, your brain just goes back into overload again because it hasn't fixed itself from before. So I think that a lot of people are believing all of this has to do with heart-lung machine, and I think a lot of it might be more centrally anxiety driven, but that still needs to be addressed, unfortunately. All right, let me check back in with Josh real quick before I let you go home for dinner. Anything going on, Josh, we need to know about?
Let's welcome Michael Ross to the chat. He
Welcome.
says, I have a 4.6 dilated root, 6.1 250, surfed and super active my whole life. Genetic testing this week. How much can a root dilate for activity? Also, have you replaced a root with someone with designated valley fever?
Designated valley fever, I can't say I have. But I guess the question is activity, right? Is that what how much activity? So, I tell people if they are, I mean, this is probably the most common question I get. At 4.6, assuming that measurement's correct, right? You're not anywhere near the threshold where we consider surgery. Especially since you're on the taller side, that's not that big of a concern as long as there's no funny morphology based on how it looks. And obviously, if your genetic testing is negative, I usually tell people, exercise is good. The benefits of exercise far outweigh the risks. And so I tell people that they can get the heart rate up, they can do cardiovascular exercise. The big thing to stay away from is really extreme lifting. So I tell people, just as a ballpark, lifting more than half your body weight. That's kind of heavy duty bench press, heavy duty clean and jerks, squats. The reality is really heavy duty lifting is probably not that good for you in general. And so lifting lighter weights, more reps, focusing on balance, focusing on flexibility, all that's probably better for you than in terms of exercise than heavy weightlifting. And so I don't really put people on any serious restrictions. There is some evidence to suggest extreme sustained cardiovascular effort can cause some strain in the setting of aneurysms, but that typically is sort of like a sprinting or endurance, like sprint cycling. It doesn't necessarily fall under kind of jogging or cardiovascular exercise, but if you're kind of an extreme athlete, then that's maybe something to avoid. But outside of that, I would say you have little restriction.
Excellent
Very
answer.
good.
Thank you, doctor.
Of course. All right, Karen,
Valdez
thank you.
says-
I'm sorry I was I'm sorry I was late.
No worries.
That's okay.
Velda says, thank you for all you do. You are amazing. And Elena gives you a thumbs up and a smiley face.
Well, we'll take that. Hey,
It is
listen,
my pleasure.
everybody, I appreciate everybody and all of your questions. Thank you so much, Dr. Eudailey, for taking your time out of your evening, even
Miss
after
Karen,
that
this
little
is Dr. Eudailey.
sidestep. Oh, what did I say? Eudailey? I meant to say Eudailey. See, I'm getting tired too.
I
You
know,
both
Ben.
start with you.
That's not an insult. So that's
We both start with you. Oh, you know Dr. Eudailey too? Yeah, that's right. I think you do. Right. Dr. Eudailey, Kyle Eudailey from University of Alabama in Birmingham. If you guys want more information, just let me know. I'll get you his information if you'd like to reach out and contact him if you're in the area and you need a doctor. He's a great doctor.
Yeah,
And,
like I said, we have a,
yeah,
it's not just me
great
here
team.
at UAB, but we have an
Great
awesome team. And
Yeah.
we, I will say, the cool thing that's happening, just a final thought, because I'm sort of thinking about it now out loud, but we didn't even touch on it, and maybe we'll save it for another date. But
Yeah.
there's so much cool technology happening that we are utilizing. And there are a bunch of endovascular technologies that allow for treatment of aneurysms, particularly after people have had either prior hemiarch operation or a more extensive arch operation, meaning that the reoperations or the reinterventions after dissections are becoming a lot easier, and they're not these big redo surgeries, meaning we're able to get some really good results with some really cool technology. We here at UAB, we're kind of the forefront of a lot of that stuff with endovascular arch repair and endovascular stenting, and there's just so much happening in that world.
We're doing that. We're going to have our next meeting all be completely about endovascular fun stuff. Yeah.
Yeah, I'd love that. Well, but at the flip side is there's also so much, even since the last time you and I talked, there's so much from an open surgical perspective that's changed in how we deal with type A dissections. And there are now multiple new devices that are on the market that are commercially approved that have gone through trials over the last 5 to 10 years. And they are very cool. There's a new device that just came out from a company called Artivion that treats patients with malperfusion. There's now off-the-shelf frozen elephant trunk devices from a company called Terumo, and all these things are just there's just so many more tools in the toolbox that we just didn't have 5 years ago, and we had not even close to that 10 years ago. And it's just, it allows us to treat a lot of more pathology and treat it on the front end, and then how we treat it on the back end for that sort of second stage or next stage procedure is all just, it's just getting better and better and better. And so I would say the cool thing and why I love aortic surgery and love this space is just because we're just moving the needle a lot big time. And there's actually, starting this year, there will be a trial looking at hopefully will be one of the first commercially available endovascular devices for type A dissection treatment, which would be a big deal.
That's huge.
Yeah, I know.
That's huge. I mean, we've been talking about with a certain company about a device, almost like a glue for abdominal aneurysms to basically coat. And so we still talk with them to find out where they are in the process. I think they're in human trial right now, but I've often said, when are we going to come up with something that we could do endovascularly for the type A? And now you're telling me that's going to be hopefully a possibility.
There's a company called Gore. Gore's very, very prominent in the space, but there's a trial called Arise 3, which we're one of the trial sites. It will hopefully be up and running this year, but ideally be enrolling this fall. But lots of stuff that we're working on, and we also at UAB have our own sort of working on our own investigator device exemption devices that we work with FDA to kind of use some other technology out there in the space. But it's exciting times because there's so much to offer patients, and I think that's part of the reason why I love it. But
well, love that too.
That's my mini UAB plug
commercial. I love it.
I think what's happening here is really very cool.
No, I do too. And I'm serious when I say our next meeting should be like a show and tell. So whether you can work on some visuals or have products and show them, we'd love to see it. I think I'm fascinated. I'm already riveted. Can't wait. I really can't. I love knowing new things because, you know, one day they're going to say, Karen, it's your turn. You got to have something done. And I'm going to want to know that there's something, you know,
Yeah.
to do. So, all right, Dr.
All right, Karen.
Eudailey. Thank you, Kyle. I appreciate
right.
your time.
Of
Everybody,
course,
do me a
anytime.
favor. Click like, click subscribe, click that bell so you're notified the next time we go live. And I thank you so much. Till the next time.
Have a
See you
good night.
soon.
Okay.
All right, you too. Bye-bye.